Thank you for joining me for this module on adjusting insulin and understanding the concepts. The expectation is not that you will be adjusting insulin if you're an RN or RD. It's just that you understand the concepts of why we would adjust it in that manner. I'd like to start with acknowledging with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank them for their stewardship of these beautiful lands over time in memoriam. What I'll cover today is a review of the current insulins in BC and their actions, choosing the right type of insulin for the right patient, so I've got some case studies, and preventing problems and the education required for patient safety. I think a proud Canadian fact is that Banting and Best were the first to inject insulin into Leonard Thompson, a 14-year-old boy, on January 22nd, 1922. We're very proud of the legacy and how insulin has saved lives over all of these years. I thought I'd provide this slide to show how insulin has evolved over the 100 years that it's been around, and that we have moved into some very consistently released predictive insulins from our originals, beef and pork and Ultralante, even the NPHs, which are not as predictable. And a reminder that BC Pharmacare covers generic brands of Lispro, Aspart, Insulin Regular, Insulin NPH, 3070, and there is special authority for Glargine U100 in the names of Basal-Glar or Semglee. However, that's going to change on March 1st of 2026. It will now be covered under regular plan. We won't need special authority. They will also provide the needles, syringes, blood glucose test strips, ketone test strips, and most recently they'll provide supplies for continuous glucose monitors in those that qualify. This chart is available on the PHC Connect Diabetes site, and it details each of the onset, peak, and duration of all of the types of insulins that are available in the Canadian market, not all covered under BC Pharmacare, but I'm going to go to the next slide to show it in a little easier way. So you can see here that the fastest insulin available on the market is FIASP, or Faster Insulin Aspart. It is not available on the BC Pharmacare coverage, but definitely on some private plans, and it is the one that most closely imitates the normal function of the pancreas. We don't release any long-acting, intermediate-acting insulin out of our pancreas if it works properly. We release fast insulin in response to the glucose levels that are rising or lowering, and we back off on our insulin release. So this insulin gets in within 5 minutes of the injection into healthy tissue. It's peaking in 30 to 60 minutes, and it's gone in 3 or 4 hours. What we mostly will see, though, are Lispro, Aspart, Glulisine, which get in within 10 to 15 minutes of the injection into healthy tissue, peaks in 1 to 2 hours, and gone in 4 to 5 hours. That should be timed with a meal and not given in between meals, with the risk of hypoglycemia because of its fast action. Regular insulin, Humulin R, Novulin Toronto, gets in within 30 to 60 minutes of the injection. It's peaking in 2 to 4 hours, and it's gone in 5 to 8 hours. So that should not be used to drop a glucose level quickly. You don't want to give this insulin and check a glucose level an hour later because it's not peaking till 2 to 4 hours after the injection. NPH is because it's cloudy and needs reconstitution. It can have a varying action depending on how you reconstitute it. It gets in within 1 to 3 hours of the injection, peaks in 5 to 8 hours, and it's gone in about 12 to 18 hours. You can see, though, that NPH has got a peak on it, and if you give NPH plus one of the faster rapid actings, you have 2 peaks that you're battling. So it is best to go with these newer insulins. Glargine U100, which I mentioned will be on BC regular care coverage as of March, gets in within 90 minutes. It does have a tiny bit of a peak on it, and it lasts anywhere between 12, mostly 18 to 24 hours. Sometimes it's dosed twice a day. Glargine U300 or Toujeo, is it lasts for 36 hours. It's in 90 minutes. It has a limited peak and it lasts 36 hours, but it is still dosed daily because it reaches a steady state, so there's no risk of stacking as you would have if you gave too many of the previous insulins I've mentioned too close together. They can stack and cause hypoglycemia. Degludec or Tresiba lasts up to 42 hours. Again, dosed daily, reaches a steady state. Because it's released so slowly, all of it is not released at on the same day. And then Icodec or a weekly lasts for 7 days. So that one is the longest acting insulin that we have. Pancreatic function look like? If we have a glucose rise by eating or taking a medication that's going to raise the glucose levels, then we should have a corresponding insulin rise. And that would keep our glucose levels between normal, which is about 3.8 to less than 10. This is why people who have a normal functioning pancreas don't have hyperglycemia, because they have a pancreas that will put out enough insulin no matter how much stress they cause or extra food that they put in. So if someone has 3 meals a day, they're going to have 3 rises of glucose, 3 rises of insulin to try to keep the glucose in normal range, but you'll notice that brown line never goes down to 0. And that's because the brain, heart, and kidneys, the vital organs of the body, require glucose at all times in order to keep functioning. So we can't ever have no insulin, because insulin is carrying the glucose into the cells in order to feed them. We need at least 2 millimoles of glucose circulating in our bloodstream in order to feed the vital organs. So that's why a critical low of glucose, hypoglycemia, is considered less than 2.8. But what happens if they're not eating? If they're not eating, they're not going to have these rises of glucose, and they will probably just require the steady amount of insulin, which means we're not going to give rapid-acting insulin to somebody who isn't eating. We may give someone fast-acting to bring it down more quickly, but definitely a basal insulin could do the trick as well. Also, think about people who are on TPN feeds overnight, or bolus feeds by nasogastric tube. We are trying to always match what a person's eating patterns are like. If they only eat 2 meals a day, we're only going to give 2 doses of a rapid-acting insulin. And remember that cortisol is a bit of a wild card because it will throw out sugar into the bloodstream and wreak a little havoc, and that's because of our stress response. This also happens with some medications that can increase insulin resistance. Steroids and antipsychotic medications come to mind. This can make the glucose quite unpredictable. So we're going to try to mimic the normal functioning pancreas whenever we possibly can. Make sure you give that insulin at the right time. The rapid-acting insulin needs to be given 15 minutes prior to the meal to have it work best with eating. If they're not eating, don't give rapid-acting insulin unless instructed by the prescriber to correct hyperglycemia, because they don't have a glucose bump or a rise to grab, for that insulin to grab, and they could have hypoglycemia. So what insulin acts when? The long-acting insulin that's given, regardless of what time of the day that it's given, depending on the insulin. So if it's NPH, normally we give that at bedtime, and that would impact the fasting glucose level that you are taking when you poke their finger before breakfast. If it's glargine, given at nighttime or during the day, it will impact the breakfast glucose as well. If it's Toujeo Tresiba, a weekly, it's going to provide basal insulin all day long, all night long, but we still would adjust that one if we want to change what the fasting glucose levels are. If the fasting's too high, we're going to give extra long-acting insulin. If the fasting blood sugars are too low, we're going to give less basal insulin. The insulin given with a meal, fast or rapid-acting insulins, will impact that meal into the pre-meal glucose level that you're taking. So you test sugars before lunch. That would be the amount of rapid acting or fast acting you gave at breakfast. You can't go back and adjust that insulin, it's already in there, but you can look at patterns and make adjustments if there are 2 or 3 days worth of patterns. If the lunch sugars are too high, it means that we didn't give enough rapid acting insulin at breakfast to bring the glucose levels to normal. If the lunch glucose levels are too low, it means we gave too much insulin for whatever food they were eating or whatever stress levels are there. So for the rapid acting insulin, it is the meal prior that impacts the pre-meal glucose that you are taking. And this is why practitioners, prescribers have to look at patterns in order to make sound adjustments. So here's an example. The fasting glucose is really great that day, but lunch is high. That means they didn't get enough fast-acting insulin at breakfast, and they should have a little bit more there. But if I increase their fasting insulin for the days coming up, and I'm taking a look here at supper, which traditionally is running too low, if I gave them too much fast acting at breakfast, that means lunch is going to be lower in the days to come because I've given extra insulin at breakfast to bring the lunch sugar down. If I give the same amount of insulin at lunch that I did before, I'm going to have severe hypoglycemia. So I need to decrease the amount of insulin given at lunch, which seems counterintuitive, but it will prevent rebound hypoglycemia, because you're anticipating if you increase fasting insulin doses that your lunch won't be as high as 14, 15, 16. Maybe it's going to be down to 10, which means I don't need as much insulin at the lunch to give to impact supper, and I already was giving way too much before. That lunch difference between lunch and supper is over 10, 11, 12 millimoles drop with the dose that I gave at lunchtime. So I know that's too much insulin on a normal day. So this means I need to look at all areas, all patterns to avoid a problem if I just adjust one of the insulins to combat the highs. We always want to avoid hypoglycemia first. So sliding scale alone is not sufficient. It is fine for short-term issues, for assessment issues, but a person should not be left on a sliding scale alone, especially if they're using a lot from the sliding scale. That means they need to get in there and order some basal insulin and maybe order some regular doses of insulin, even if they're NPO, because maybe their glucose levels are running too high due to stress or steroids, other factors. So what happens here? Sugars are 6, I give nothing because the sliding scale says not to. And what happens is the sugar rises to 14. Well, now I go to my scale and I said, oops, I've got to give 4 units of insulin and that will bring it down. Well, sure it did. But then what happens again? I don't give any insulin. And now it swings up to 16.5 and I give 6 units of insulin to bring it down. And now, oop, that's a bit much, and they go low. If you can see this zigzag line here, this does more damage to the insides or the intimal lining of the blood vessels than if we had the sugars high and allowed them to come down nice and gently with gentle adjustments. That shearing of the intimal lining of the blood vessels is what happens when we do this normal glycemia to hyper, normal, hyper, hypo. So what we should do, according to Diabetes Canada clinical practice guidelines, is give a long-acting insulin once a day, and then we give a rapid or fast-acting insulin with their meal. And if they need a little extra because their 10 units of Admelog isn't enough and they're now into double digits, we give a correction factor. And so that might just be a little addition to the dose that they're already getting. If they get Admelog 10 units, maybe this is the sugars are high enough to receive 12 units of it according to their correction factor. And this tells us, oh my goodness, every day they're using an extra 2 units of Admelog. So now I'm going to increase their dose of Admelog to 12 units TID and keep that correction on board to continue to assess. And of note, we should not be giving Humulin R to somebody who has normal gut function and is eating. If they have gastroparesis or any form of constipation, Delayed emptying of the gut, that's when Humulin R would be beneficial because it doesn't peak for 2 to 4 hours, but the rapid actings should be given to someone who has normal gut function. So if they're NPO for procedure, we can give the regular or rapid acting insulin if their glucose levels are higher, but we shouldn't really be giving it if they are less than 10-ish, 11-ish. They may need a correction supplement after the procedure. And if they're able to eat following an early morning procedure, so they went for something at 8 o'clock, they're done at 9:30, and they come back and eat their breakfast, you could give that rapid acting insulin with the breakfast and just wait until after the procedure. The basal insulins should be given, especially in type 1 diabetes, who has no ability to make any insulin whatsoever. Often a common practice is to give half the usual dose of the basal insulin the night before the procedure. However, if someone's running higher glucose levels, you're going to want to give the full dose because they may go into the procedure with too high of a glucose level that the anesthetist or surgeon is not comfortable with continuing the procedure. So if they have normal glucose levels, we may want to decrease that basal insulin the night before, but if they are running higher, we want to give the full dose of basal. So what do patients need to know about insulin? And this is where we can, in the hospital, be good examples for them. So showing them how to use the insulin pen, preparing, injecting, and disposal of the sharps, rotating their injection sites, not reusing any needles, because at home they have the potential to do that, whereas we don't in hospital with the safety needle devices. Safe storage of the insulin so that they are not allowing it to get too hot or frozen, because that can inactivate the action of the insulin. Signs and symptoms and treatment of hypoglycemia and preventing it, as well as driving guidelines. Carrying a glucose source with them, 15 grams of carbohydrate. That can be done in the form of nasal glucagon or Baqsimi as well, which is covered under BC Pharmacare. Signs and symptoms and treatment of hyperglycemia, if they have high sugars, and you can go to that module for more specifics on that, and adjusting insulin according to their carbohydrate intake if they are capable of that type of learning. This allows them to understand that if the glucose levels are high, they need a little extra insulin. If they're low, they might not need as much, and really does help prevent admissions to hospital when they know how to adjust their own insulin. Diabetes Canada has excellent handouts, and we have some things on PHC Connect as well in the library on how to start insulin as well as all things diabetes. So I've got a few case studies here that I'm going to. So here we have a 58-year-old gentleman. He's post-MI, type 2 diabetes on multiple daily injections, or MDI, of insulin before coming to hospital. Home regimen is Basal 22 units at bedtime, Admelog 14 units TIDAC, and he's on a tiny little bit more here in the hospital, and they've added a supplemental sliding scale, TIDAC. Take a look at each of the meals, breakfast, lunch, supper, and bedtime glucose levels, and take a look as well as whether any insulin was held and what the impact of that holding has done. So my question to you is, would you hold the Admelog on breakfast at day 4? Sugars at 3.5. Take a look at day 2. Sugar was 3.2, Admelog was held. They ate their breakfast. It rebounded to 21. Extra insulin was given at lunch because it was high. It rebounded low. Admelog was held again, and now it's high again. So take a look at the impact of what holding that Admelog would do. If they're eating a meal, they should receive their rapid-acting insulin, because it will, treating a low glucose of 3.5 and then walking away means that it's going to rebound because they're putting extra food in their mouth, and they don't have a functioning pancreas. They need it. I also want to take a look here at whether you would suggest something else to help balance these glucose levels. Take a look at breakfast. They're a little too close to the line here, aren't they? They're making you make a decision as to whether you should give the Admelog or not. So that means they're too close to the line. The person is taking a little extra Basal than normal at home. perhaps that basal dose is a little too high. If we dropped it down to 22, that will drop the insulin levels the whole day long, increase the levels all day long because it's 24-hour action. So this will start the day just in a little better zone. Maybe we're now getting into the 5s as opposed to sitting in the 4s and 3s, which means you're not put in a position to decide whether you should give the Admelog with breakfast because it's not drifted too low. That way we're not into these rebound situations of holding, overreacting, and holding. So that might be the first step the provider does. Now here's an 84-year-old woman admitted to rehab after her fractured right hip repair, and she's got pre-existing type 2 diabetes. So she's currently on Basaglar 21 units at bedtime and Admelog 5 at breakfast, 7 at lunch, 5 at supper, and none at bedtime. She's also on prednisone titrating doses, and they added another order of Humulin R sliding scale QID, and there's the sliding scale to the right. So let's take a look first of all at the columns, breakfast, lunch, supper, and bed glucose levels. Well, there are some that are high, some that are low. So when you're coming on board and day 4, the glucose at breakfast was 12.5, you had to give a little extra Admelog and a separate dose of Humulin R because of the sliding scale, and now the sugar went down to 3.6, putting you in a position of, do I give the insulin? Well, of course you wouldn't be giving sliding scale because it's not over 10, but if she's going to be eating, then she needs to take her Admelog. This will help balance her out. So then we take a look at whether there's an issue with the Admelog TID and the Humulin R sliding scale. This will happen more often than I care to say, in that the prescriber isn't really looking at what the person's already on, and they're just adding a type of insulin that doesn't match the rapid or fast that they're already on. Nobody should be on a rapid insulin TID plus a fast-acting sliding scale. That is 2 separate insulin pens, 2 separate injections, 2 separate time action profiles. So that's the first thing that needs to be addressed with the prescriber. Get off this Humulin R sliding scale. It's very aggressive. 2, 4, 6, 8, 10, 12, according to this scale here, is too much. And she would require a correction factor or supplemental sliding scale of Admelog, and I would do it at TID and not for QID as well. Rashi is a 63-year-old gentleman with type 2 diabetes for 11 years, A1C is 12.3%, fasting glucose 14.5, and he's 100 kilos, or a BMI of 35. He's currently on metformin and dapagliflozin pills, and he tried semaglutide, but he didn't like the side effects. So next steps are, we cannot give another pill that will drop his A1C to less than 7 from his current levels. So he will need multiple daily injections of insulin. The typical standard recommendation is that we have 0.3 to 0.5 units per kilo of a total daily dose. He's 100 kilos, we'll take 0.4 units per kilo as a guideline, and his total daily dose should be 40 units of insulin to start. 40% of that insulin, or 16 units, should be long-acting, or basal insulin. So we're going to give 16 units of glargine at night, and the remaining 60% that's left, or 24 units, is going to be split between 3 meals. So we'll start with 8 units of Lispro, TIDAC. So that is how a practitioner would start someone on multiple daily injections of insulin. And then finally we have Lynn. Lynn is 56 years old. She has type 2 diabetes for 7 years. You come on today, she's on Basaglar 45 units at nighttime, Lispro 15 units at breakfast, lunch, and supper, none at bed. And she's her glucose at 1700 is almost 25. Have this information handy for the prescriber. What are the sugars for the past 2 days, 4 times a day? Hopefully you have them. How much insulin was given at lunch, and was it held? And if so, why? Was the full dose of Basaglar given at bedtime the night before? That will impact what her sugars are that day. So if the full dose of Lispro was given at lunch, the prescriber may say, okay, give 20 units of Lispro at supper time today, and we'll see how it goes. And they may add a supplemental sliding scale. If the full dose was not given at lunch, why? Was she away for a test, didn't get back till 2:30 in the afternoon, and didn't feel like eating, so it was skipped? The prescriber may just give the normal 15 units of Lispro at supper, knowing the dose was missed at lunch, and then add a supplemental sliding scale. And it's also important to know that if the basal was either held or reduced the night before, the entire next day is going to run higher, right? So the key learning points are, before intensifying insulin therapy, it's really important to assess the dosing administration, adherence, did they get the insulin or not, and the average fasting glucose readings. Basal insulin targets fasting readings, so we know all basals will improve or adjust fasting glucose. And if the fasting reading is not a target, an increase in dosing may help to reduce the A1C, because they spend a longer time overnight in high glucose levels. But with the basal, they're not eating, they're not getting checked overnight, so they may spend 8 or 10 hours in a hyperglycemic state, as opposed to being checked on more frequently during the day. And the guidelines recommend the addition of a GLP-1 receptor agonist like Ozempic or Mounjaro, an SGLT2 inhibitor like empagliflozin, dapagliflozin, or a DPP-4 inhibitor like the Januvias for people who are on basal insulin and not reaching A1C target. GLP-1 receptor agonists can be added to basal insulin, either as a separate medication or fixed ratio combination. In certain provinces, they have a combination of basal insulin plus a GLP-1 all in one pen. And it's important to engage the patient in the choice of therapy when intensifying beyond basal insulin, because they need to be on board for that.